This recording is going to cover the control of cardiac output. It's the first part in which we're going to do a basic introduction, give you some terminology, look at the role of the autonomic nervous system in controlling cardiac output, and addressing factors that affect heart rate. The second part will look at factors that affect stroke volume. Now the equation for cardiac output is heart rate times stroke volume. Now cardiac output is the volume of blood that is ejected from the heart per minute. And resting cardiac output's about 5 liters per minute. That's averaging males and females. Males is a little bit higher, girls are a little bit lower, but average is about 5 liters per minute. The two things, since it's a rate, the two things that comprise cardiac output is the heart rate, how many times the heart's beating per minute, and then stroke volume, which is the volume of blood that is being ejected from each ventricle per minute. Now, as a kind of a general rule, is our blood volume's about 5 liters. So we do eject about our entire blood volume out of our heart every minute. Now, the purpose, again, of maintaining an adequate cardiac output is to ensure that we have an adequate blood supply to different tissues in our body. We have to supply nutrients, we have to supply oxygen, we have to remove waste products, and it is going to be very important that cardiac output can be changed based upon your metabolic need. The more metabolically demanding the situation is, the higher the cardiac output is needed. Now, I wanted to show you some of the terminology that you have seen prior to this. Is obviously heart rate is a component of cardiac output. Contractility is what determines your stroke volume. How forcefully the heart is contracting will determine stroke volume. Now, preload and afterload can also affect your cardiac output. Preload is a volume load. It's a load placed on the heart prior to contraction. So think of it as your end diastolic volume. Afterload is a load placed on the heart after it begins to contract. So that's where you have pressure in, say, in the aorta or in the pulmonary trunk. That pressure needs to be exceeded to get the semilunar valves open and the blood out of each ventricle. And if afterload is too high, it could cause effects on your stroke volume. So all of these things are very important components technically of your cardiac output. Now what we're going to do is we're going to look at, since this is the equation for cardiac output, we're going to first be looking at factors that affect heart rate, such as the autonomic nervous system and hormones. And then the second webinar is going to cover factors that affect stroke volume. I do want you to realize there's a lot of kind of crossover between the factors that affect stroke volume and the factors that affect heart rate. Hormones in the autonomic nervous system can also affect stroke volume. So I just want you to realize there is a lot of kind of crossover between the two. Now, before we start looking at things that could affect cardiac output, I have to go over some terminology. So the first the terminology we're going to look at is things that have what we call chronotropic effects. Chrono means time. So if a factor has a chronotropic effect on the heart, it affects heart rate. And if I say something has a positive chronotropic effect, that means it increases heart rate. If something has a negative chronotropic effect, that means it decreases heart rate. So I'll give you a couple examples. Factors that could increase heart rate is the sympathetic nervous system. That would be one of them. Other things, if you're in sympathetic mode, the adrenal medulla will be releasing epinephrine and norepinephrine into the bloodstream, and they could increase heart rate. Other thing that could increase heart rate would be your thyroid metabolic hormones, like T3. These all have a positive chronotropic effect on the heart. Those that cause a negative chronotropic effect would be the parasympathetic nervous system. Specifically, the vagus, because the vagus is the cranial nerve that innervates the heart. So parasympathetic nervous system, and also things like beta blockers, which are medications that we'll look at a little bit later, and a medication called digitalis that can also decrease heart rate. Now, the factors that affect contractility and therefore affect stroke volume have inotropic effects. So the inotropic effects on the heart, they affect cardiac contractility, and if I say something affects or has a positive inotropic effect, it means that it increases contractility and therefore stroke volume. If I say something has a negative inotropic effect, that means it decreases, hope I spelled that wrong, sorry. It's just a T, contractility, and therefore decreases stroke volume. So some examples would be for positive inotropes. That's a term I could use. If something is a positive inotrope, that means it's a factor that increases cardiac contractility, is sympathetic nervous system. And I'm just going to abbreviate nervous system as NS right now. Again, norepinephrine and epinephrine released by the adrenal medulla. And also the medication digitalis. So you'll notice I previously said digitalis decreases heart rate, but it increases cardiac contractility. This is a medication that's used to treat, it's coming out of favor because it can have toxic effects on the heart. Digitalis was given for people who are in heart failure. And so to try to, their cardiac output wasn't good. And so people will be like, well, that doesn't make sense. If I want to increase cardiac output, I should increase contractility as well as heart rate. Well, is the changes in contractility have a much more impact on increasing cardiac output than changes in heart rate. If you increase heart rate, you're going to spend more time contracting, and that's actually inefficient. So we want to be able to spend less time contracting but make those contractions more forceful. That's a better way of increasing cardiac output. And so digitalis does that. It increases contractility, but it decreases heart rate. Now, factors that decrease stroke volume by decreasing contractility would be if you inhibit the sympathetics, and also things like beta blockers. Now, you'll notice I didn't put parasympathetic for here, because you're going to see it very shortly why I actually don't really say it as parasympathetic nervous system decreasing contractility. You'll see why in a moment. So these are kind of two important concepts: chronotropic effects, inotropic effects. Chronotropic affects heart rate, inotropic affects stroke volume. Those both obviously could affect your cardiac output. So let's look at the autonomic nervous system and its effects on the heart. Now, the autonomic nervous system, in the medulla oblongata, we have a cardiac center, two of them, in the medulla oblongata, and we have a cardio-acceleratory center and a cardio-inhibitory center. So it kind of makes sense. If you think about what those words are, you can probably figure out which each does. But a cardio-acceleratory center is going to be somehow stimulating the heart. A cardio-inhibitory center will somehow be inhibiting the heart. Now, this cardiovascular center is located in the medulla oblongata, and what we're going to do is we're going to have various innervation to the heart. And we're going to start with looking at the parasympathetic division. Now, the innervation of the heart by the parasympathetic is completely via the vagus nerves, cranial nerve number 10. Remember, vagus means the wanderer. So the vagus innervates the heart, and it has the preganglionic fibers that go to, we call the cardiac plexus, and then postganglionic fibers will then innervate various components of the heart. And predominantly is you have innervation to the SA node, the AV node, and atrial muscle. You do not have innervation by the vagus to the ventricular muscle. So that's going to be an important thing to remember, is if something innervates portions of the cardiac conduction system, like you see here, somehow it'll affect heart rate. Now, if you affect the AV node, that's going to affect conduction from the atria down to the ventricles. Through remember, the AV nodal delay that's important for allowing the ventricles to fill. So that can affect that delay that you normally have as the impulse goes from the SA node ultimately down to the ventricles. If something affects the muscle, that will affect contractility. Now, since when we talk about stroke volume, we're predominantly going to be talking about what's being ejected from the ventricles. So if you notice, I said it innervates the atrial muscle, but it does not innervate the ventricular muscle. That's why the vagus doesn't have huge effects on stroke volume, because it does not innervate the ventricular muscle. Now, the parasympathetic division pretty much dominates under normal conditions. While you're just sitting here, you're pretty much, we call them rest and digest. The vagus is what's going to be controlling the heart, and it's primarily controlled by the cardioinhibitory center. Let's do a different color here, of the medulla oblongata. We're doing the parasympathetic. So let's look here. So this actually shows you the vagus. So you have SA node, which is what's going to affect heart rate. You have innervation to the AV node, which will affect that AV nodal, or that impulse going from the AV node through the bundle of His to the ventricles. And you notice I don't have the innervation to the ventricular muscle. So what is ultimately the effects of the parasympathetic nervous system innervation? Well, you still have to go down to the level looking at what receptors are involved. What's the neurotransmitter? So with parasympathetic input, it uses the vagus nerve, releases acetylcholine as the neurotransmitter. And what you'll notice is we have a muscarinic cholinergic receptor. These muscarinic receptors are G protein coupled receptors. They are different, remember, from nicotinic receptors, which are ligand-gated ion channels. The muscarinic receptors, depending on the specific one and where we find it, will have various effects. And we're specifically looking at what's going to happen in the heart. What so happens when acetylcholine binds to its receptor on the heart, it does two different things. It closes T-type calcium channels. Now, in the SA node, that's where you have these T-type calcium channels, and therefore, if you close up calcium channels, that's going to affect heart rate, because these are found in the SA node. You also are going to open up potassium channels, because potassium is so highly concentrated inside the cell. It's going to want to leave, and when you have a loss of positive charges, that's going to result in hyperpolarization, which means you're further away from threshold. That also is going to affect the rate in which we depolarize the cardiac muscle, or in the SA node. So what you'll notice overall, let's go here, the effects on SA node is what you see. Here's normal, and here's with parasympathetic innervation. You notice this is a little bit less steep than here, so it's going to take longer for you to reach threshold because you're hyperpolarized, and it has a slower rate of depolarization because of, again, we've closed up these T-type calcium channels. So overall, what happens with the SA node is we decrease heart rate. Okay, so we decrease heart rate because, again, I should say opening potassium channels, which leads to hyperpolarization. I'm running out of room. And you decrease the rate of depolarization. Because, again, you're closing T-type calcium channels. So overall, the effects of parasympathetic innervation is primarily a decrease in heart rate. Just think about it. Does it make sense? Rest and digest, your metabolic activity is much lower. You don't need a faster heart rate. Now, if we look at sympathetic input, actually I'm going to come back here to show you the innervation of the sympathetic nerves, is the sympathetic division. We're going to have preganglionic fibers from the sympathetic trunk or the sympathetic chain ganglion. So here are the preganglionic fibers here. The cell bodies of postganglionic fibers are found in that sympathetic chain ganglion, and then we're going to have those fibers innervate various components of the heart. And you'll notice we have a lot more innervation by the sympathetics. It does innervate SA node and AV node, so it's going to affect heart rate, conduction, and it also affects both the atrial and the ventricular muscle. So it's going to have effects on contractility. Now, if we go here with sympathetic input, and I'm going to do this because I don't want you to, I'm going to cross out this because we're specifically right now addressing the sympathetic nerve innervation. It releases norepinephrine. Okay, the reason why they had norepinephrine, epinephrine on here is if you have the release of epinephrine and norepinephrine from the adrenal medulla, it's going to bind to the same receptor. But with sympathetic nerve innervation, norepinephrine is the neurotransmitter. The receptor is a beta-1 adrenergic receptor. It is a G protein coupled receptor. So the beta-1 adrenergic receptor, well, how it works is its specific type of G protein coupled receptor, or G sub S, is what happens as a result of it is you're going to see activation of adenylate cyclase, which produces cyclic AMP. Well, this activates an enzyme called protein kinase. And what protein kinase does, it phosphorylates a number of different things. And what happens here is it does two different things. When it phosphorylates the funny, use that funny sodium channel, is the funny sodium channels, remember, are in the SA node. Remember, they're called funny because they're not responsive to tetrodotoxin. Tetrodotoxin does not affect those channels because they're different from other sodium channels. Well, if you open up those funny channels, it activates them, sodium comes in the cell. So that will depolarize the cell. Also, that protein kinase phosphorylates these T-type calcium channels, which again are important in when we look at heart rate, and also calcium is going to be very important in contractility. So we have an opening up of these calcium channels, calcium comes in. Ultimately, all of them contribute to depolarization. So what we're going to see as a result on, say, the SA node is you see a much more rapid depolarization here. We're closer to threshold, and you have a reduced repolarization. So ultimately, if you just count here versus this, heart rate has increased. So that's one of the things. So it increases heart rate by increasing depolarization rate and decreasing repolarization. Also, what it does besides increase heart rate is it increases cardiac contractility because of its effects on the muscle. so which leads to increase in stroke volume. So the effects of the binding of norepinephrine to the beta-1 adrenergic receptors leads to opening up of calcium channels and the opening up of sodium channels, both of which help with increasing heart rate and increasing contractility. And think about it, sympathetic innervation, you're in fight or flight mode. You want to have an increase in cardiac output. You want more, your heart rate's going to increase, your cardiac contractility should increase in response to that. Now, kind of linked to what we just talked about with the autonomic nervous system is this thing called the Bainbridge Reflex. It involves the autonomic nervous system and it will affect heart rate. What happens as a result of the Bainbridge Reflex, or say what triggers it, is if we have an increase in volume going to the right atrium, so an increase in venous return, you'll have more blood in that right atrium. Well, stretch, so this is the variable, is you have stretch of, or the variable's volume, which leads to stretch, and we have specific stretch receptors in the right atrium. That sensory information is going to be carried along the vagus nerve. Remember, the vagus nerve is a mixed nerve. So that sensory information gets sent to that cardioregulatory center in the medulla oblongata. And what happens, so that's the integration center. From there, it says, okay, we have more volume in the right atrium. I think we don't want things backing up. We need to get it out. We need to get heart rate up. And so the information, the efferent information, is going to be carried along the sympathetic nerves back to the SA node, and the ultimate effect is an increase in heart rate that's about 40 to 50% higher than rest. And this is a true nervous system reflex. You have your variable, you have your sensory receptor, you have an afferent pathway, efferent pathway, and our effector would be the SA node. And ultimately, we're going to increase heart rate. Now, other things that could affect heart rate would be hormonal effects. So I had previously mentioned the when you're in fight or flight mode. When you're in fight or flight mode, the adrenal medulla is going to be releasing epinephrine and norepinephrine into the bloodstream. So you're going to need to increase your cardiac output if you want to fight something or you want to run away from something. So you're going to have both a positive chronotropic and inotropic effects of epinephrine and norepinephrine released by the adrenal medulla. Now, and it's still by binding to the beta-1 adrenergic receptors, just when we just looked at previously. Now, thyroid hormones also will affect this. Sorry, that's the same thing you saw before. Is thyroid hormones also will result in increase in heart rate and contractility, but how it does it, it's actually the thyroid hormones increase the production of the beta-1 adrenergic receptors. So having thyroid hormones is important for you to be able to respond to sympathetic nervous system stimulation because you need those beta-1 adrenergic receptors. So the more T3, T4 that you have, you'll increase the number of beta-1 adrenergic receptors, which will make you more sensitive to sympathetic input, or the epinephrine or norepinephrine that is released by the adrenal medulla. So the thyroid hormones ultimately also promote increased heart rate and contractility. So think about people who are hypothyroid. Their cardiac outputs tend to be low, their heart rates are low. People that are hyperthyroid, their cardiac outputs are greater, their heart rate's greater. Now, one other thing that we're going to be looking at is the role of venous return on heart rate. Now, venous return is that volume of blood going back to the heart from the venous system, okay? It has an indirect effect kind of via that Bainbridge reflex. And plus, we're going to show you another one. So I had mentioned that with that Bainbridge reflex, if we have an increased venous return, that leads to stretch of the atria, sends the information to the medulla oblongata, and as a result, we have an increase in heart rate. But we also have an increase in heart rate that's not mediated through the autonomic nervous system, that's affected by venous return. In your right atria, you have those pacemaker cells, the P cells. And if you have an increased volume of blood in the right atrium, it stretches those P cells. So the P cells in here, they stretch, so that's going to have mechanical effects. You're kind of deforming the membrane, makes it more permeable to those sodium ions. And as a result, it depolarizes a faster rate. So just stretch of those P cells is going to lead to an increased depolarization rate of the pacemaker cells, and heart rate increases. Now it's only about a 10 to 15% increase in heart rate over baseline compared to the Bainbridge Reflex. So this is actually innate. There is no nerves that control this. So it's just, if I took the heart and denervated it, took all the nerves that innervate the heart and removed it, but I put more blood into that right atria, heart rate will increase. So we have venous return that's directly and indirectly leading to an increase in heart rate. We have the Bainbridge reflex, and we have this innate atrial stretch that leads to an increase in heart rate. Now this is the last bit of looking at things that affect cardiac output, looking at autonomic nervous system and the role of things that could affect heart rate. The next one is going to look at factors that affect stroke volume.